So robots are here to stay. These are my disclosures. I don't really personally think there's any debate here. The real robots are going to eventually make their way into every part of surgery. The only question, the debate is, are robots ready right now for prime time? I think that's what I would ask my co-debater, Tom Skolko. Are we ready right this moment for robots? Robots are being used in industry, they're being used in other surgical specialties, they're everywhere, and they make things more precise. Are we ready right now? Now let's just go through a little history of orthopedics with robots. It was first used in '86. The first RoboDocs and other companies started using robots in '92. So this is not a new thing. It's been tried a lot. So why would we even think about using robots? We got one of the most successful operations in the world, 20-year survivorships by multiple people, multiple different prostheses, greater than 95%. Because we still have all the reports that our patients are not satisfied 20% of the time or more. In the best of hands, many people in this audience that are well known have published papers where 30% of their cases are outliers. They're greater than 3 degrees outside what they're targeting or outside this, what you heard before, this mechanical neutral alignment. That, look at your own cases, you'll realize that that happens unless you're really doing certain specific things. So the question is robots ready for prime time to change that? So I'm going to try to present what we're doing right now and what's been going on in the last bunch of years for more modern robot systems, which are now designed to be a little bit safer and have a low learning curve, which is not typically what you get with new technologies. Usually you have a lot of complications and there's a large learning curve. Now, this is an interesting editorial that just appeared in JOA by Dr. Booth, Sharkey, and Parvizi, and they really criticize robots right now. Is this really an innovation or just a marketing ruse by the companies? And that's what they say. This has been fostered by industry rather than academia, and what they mean by academia is study. Is this just being put up and here, this is a nice thing to use, why don't you try it? The patients want to hear about robots. Well, I'm going to show to you that this is some of my work, but I'm also going to present other centers that it's not just been companies, there's actually been a lot of basic science and clinical research. This is a study that we did comparing robots to manual in terms of alignment with cadavers, and we looked at CT scans to check it, and you can see that the alignment parameters are much tighter. That's the purple with the robot versus manual techniques, and that's not surprising. I mean, you can. I think anybody could reproduce those type of results using a robot versus manual techniques in a cadaver. And I would also proffer that you could do the same thing using robots with many of the new designs, not just one specific robot system, but many of them. Another interesting thing, when many of the robots have these haptic boundaries, so your blade can't cut past a certain place, and therefore you're not going to cut the PCL because a bone island gets created. And you're not going to cut your MCL because it has boundaries. The blade can't go there. So in fact, it can become a safer procedure. I'm not saying it absolutely is if you do something completely wrong, but it can have the potential to be safer. Those are cadaver studies. What about the clinical studies? There's plenty of these. This is one by Marchand, his first 330 cases. He's done like 2,000 now. He got 100% of the valgus knees corrected within 3 degrees of neutral biomechanical axis targets, and of the non-severe varus, the ones that were less than 10 degrees, he got 100% corrected. That's in his first group. Let's go back to that article where they criticize things and say, you're going to spend more time doing a robotic surgery. Was that really true? The first 20 cases take you longer because you got to set the thing up and you got to put some tracker pins in. So they take like 10 or 15 minutes longer. These are 2 surgeons. One of them is Art Malcani, Louisville, Kentucky. He was a big skeptic of using the robot. He didn't really want to do this. It was taking him 20 minutes longer. But after he finished his first 20 cases, got used to the setup, you could see that the times became the same. And in fact, this is Marchand's cases. after 6 months of doing about 300 or 400 cases, he doesn't have to repeat all these things. He doesn't have to go back and forth. He gets used to the robot. When you're doing certain types of cases, your times actually get lower than your manual cases, which occurred at 6 months on that curve. The robot is the top curve that dips down. Okay, if you're doing ambulatory surgery and you can't have all this inventory, you want size prediction. Well, a lot of these robots are based on CT scans or different methods to predict the size of what components you're going to use. This is an initial study showing that 95% of the femoral tibial components were within one size. Okay, you could say you can get that in other methods of just radiographic templating and things, but now we can actually do this 100% of the time. So that's pretty important for ambulatory surgery. The real thing is, are we getting good outcomes? Well, there's some studies we've done, this is Marchand's work, where the outcomes were actually superior than already pretty good manual results. These were WOMAC scores at 6 months. This is Faris Haddad's study where he compared a group of manual to robot knees. Small group, maybe forgetting the numbers exactly, 50 versus 50, but he was getting much better results with a robot in terms of pain and decreased and better functional results, shorter times to discharge. This is another follow-up study to the one we did at 1 year, showing improved outcomes with robots versus manual. And then we're getting, this is not a comparison study, at 2 years finally getting excellent results with robots from 6 different centers. Radiographs also getting improvements compared to manual with some studies. This is something that's not usually studied. I was pretty interested in that. You know, I'm getting older, I turned 60, and I get a little worn out after these long days, and nobody's really studied surgeon posture, ergonomics, and we all have this incredible number of neck injuries and lower back injuries. Well, I can tell, I tried to do this study of how many steps I take when I do a manual versus a robot, but you wouldn't believe it. I can do robotic knee surgery and take 0 steps. I can do the whole case. I can't do a study like that, but we put all these sensors on and we looked and we showed that there's less task complexity, demand, lower, much better ergonomic parameters. Did a number of studies, they're about to appear, and the surgeons are much more satisfied when they do a robot versus a manual. I mean, I don't know if that's a real study, but we enjoy doing it. It's more fun. Maybe it's just because it's something new. What about the cost, the elephant in the big elephant in the room? These authors, these critics say that even if it was that they would still think that this is a great thing to use if it was cost effective. And I know these robots and many of these things cost a lot of money, but we did this study after you start using the robot. We looked at robotic cases, matched 5-to-1 propensity matching to manual cases, and look at the numbers we found. These are billings to Blue Cross, Medicare data, and $2,500 less cost for the robots in this group of patients. And that was just presented again by Carlos Laverni at the Knee Society as well, another group of patients. So I'm showing all these different robots. You can see a lot of different companies on this slide. I think I'm allowed to do that because I'm not picking one company there. But I would have to say it's a wave of the future. Everybody's doing this and trying to do this and improve this. And it's a logical thing. Why would we think that our society would not move to robotic surgery or robotic things in the future? I mean, that's part of human evolution. That's part of science. That's what we want to do. The question is, are we ready right now to be doing it for everybody in the audience? But we're moving in that direction. So I won't repeat some of the things. And the other final criticism, they said, adding a robot, this group, is like bringing an electronic medical record to your clinic. Well, another thing, you could add a robot and use it on Saturday, and you can bring it on the golf course on Saturday morning as your partner, or as the tool you use and get a hole-in-one. So you can't do that with an electronic medical record. Thank you.